Hello, everyone, and welcome. So the plan is that I'll go through the slides in a case. You guys ask all the questions, and Kara is going to answer all the questions. So here we go. Mild cognitive impairment, MCI, biomarkers, and disease-modifying treatments is our focus. Next slide. So 3 objectives to describe mild cognitive impairment. We'll discuss use of biomarkers to identify causes of mild cognitive impairment. So not just Alzheimer's, but say vascular cognitive impairment, Lewy body, so forth. And then we'll talk hopefully a good amount on the risks and benefits of disease-modifying treatments for MCI due to Alzheimer's disease. Next slide. So we'll go to a case. This patient is from my private practice, 74 years old, white. The race is important because if we go into the testing phase like ApoE4, then the risks are different in different racial and ethnic backgrounds. Also, a lot of the biomarker tests on p-tau that I'll be talking about are done primarily in the white population. And then again, same thing applies to disease-modifying agents. So he's a 74-year-old pharmacist. So again, he's very well educated. His wife is a pharmacist, very well educated. So the level of conversation was at a whole different level. And he came with, he felt was 6 months of short-term memory loss, where he would forget things, misplace things, have difficulty finding words. And he felt that it was probably increasing. Now, he was still working full-time, and because of the stress, he decided to reduce it to part-time. He was feeling very frustrated at work. He had missed a couple of meetings. His wife had noticed that the problems were actually probably going on for a year. And this was all very insidious onset. So the onset was important because if it's like a sudden onset, I would think of a stroke. Also, along with this onset, there was some mood symptoms, anxiety and depression, but he has long-standing history of anxiety and depression that has been well controlled, well managed. He's on an antidepressant, sertraline, 75 milligrams. And we went through a long list of other sort of symptoms. Just keep it up there, Lindsay. Thanks. Yeah. Long list of symptoms like, did you have visual hallucinations? Did you suddenly get confused? Did you have falls, incontinence, change in personality? To identify many other neuropsychiatric symptoms that might accompany the primary concern of memory loss. And the good news for him was that it was all negative. So there was no history of, say, visual hallucinations, tremors, change in handwriting that would indicate Lewy body disease or Parkinson's. He didn't have any major physical health problems that were severe, like severe liver disease, heart disease, so forth. Then I went through a long list of like modifiable risk factors. There are 14. And then there are 3 more from the American Heart Association. And a lot of these things we know, hypertension, diabetes, and so forth. So anyway, so there was a long list of questions. And also his symptoms of memory impairment would fluctuate. So sometimes he would just feel he's just totally fine. He did report that there is a family history of older sister and mother having dementia. But both of them had dementia in their late 70s, like 78 and 79. So I told him that, generally if you worry about genetics, especially if the onset is much younger. But again, he had witnessed what had happened to them, and he was really worried. I don't want to get dementia. I don't want to become mean. I think it is getting worse. I don't have the confidence in me that I used to have. Avoid meeting friends because I don't have to embarrass myself. I can still drive. I can take my medication without mistake. So it tells you how much he's worried about this. Uh, then again, medications can cause MCI, mild cognitive impairment. So, but none of his medicines look concerning. Uh, the primary care physician had referred him to me because the PCP felt that this was just age related with stress. Uh, his Montreal Cognitive Assessment score with the PCP was 26, primarily only in the area of like recall impairment. Everything else was fine. But he and his wife felt that this was not just normal part of aging, so they asked for a second opinion. So that's why I did all the whole assessment. In the physical exam, again, I looked for tremors, some focal neurological deficits. None of that was seen. His gait was fine. Uh, Vital signs were fine. Again, you look for autonomic instability sometimes. You might see that with Lewy body disease. His mental status exam, again, was, fine in terms of, mood, but he did repeat himself. And sometimes he was not aware of it. And that to me mattered because lack of awareness would be more worrisome. He would ask the same questions again. He was not aware. He had some word finding difficulties, but they were really very minor. The main thing was repeating himself. And I did a Montreal Cognitive Assessment score, and it was 27. So he was he was glad it was 1 point better. I didn't have the heart to say him. It could just be fluctuation. And then one of the handouts is the brain care score. So it's not like a highly research supported scale. Look it up. It tells you, gives you a score depending on your lifestyle and control of cardiovascular risk factors. So he didn't do well, 11. And he's a nerd. He likes to read. He likes to teach. He wasn't exercising a lot. He wasn't eating healthy. His wife was on the other side, exercising, eating healthy, telling him like for 100 years to do that. But, sometimes how husbands are. Anyway, so he didn't score well on the brain care score. So to me, he could dramatically improve in his brain healthy lifestyle. He thought it was just normal alcohol intake. His PCP felt the same, but I thought, even that amount of intake, 7 to 14 drinks, maybe it's best not to do it. The key assessment was function, because if his function was significantly impaired, where he couldn't do his taxes, and he has always done it, he would get lost in familiar places. If I saw all that, I would worry that this is like more than MCI. This looks like dementia. And one of the scales I use is functional activities questionnaire. So I'm curious what your thoughts are on all these scales and all. But anyway, he didn't score high, which is a good thing, which showed that he's quite functional. He needs now some assistance from his wife. Next slide. No, just go down a little bit. So again, I told him that we've identified a lot of things we can do, and we've done blood tests and didn't really show anything, which is a good news. His hemoglobin A1C was in the pre-diabetes range, so it could improve. eGFR, 66 could be 96. That would be better. Anyway, the brain MRI, I told him this is normal at age of 74. So, if I would be worried if you had hippocampal atrophy, if you had atrophy of the medial temporal lobe, if you showed a lot of evidence of moderate to severe white matter hyperintensities, you would see lacunar infarcts in the brain. It can have silent infarcts, unfortunately. He didn't have any of that. So I said, this is good news. You don't have microbleeds, you don't have macrobleeds. So, but But I said that if you really want to know whether this is due to Alzheimer's disease, then we have to go into the biomarker range. Well, again, they had done their homework, so they wanted the biomarkers. So we did a p-tau 217. Unfortunately, it was elevated. So then we had to talk about that, because before I started, actually, I asked him, what happens if we do the assessment and you get a label of MCI? Because now even labels like MCI can have a lot of existential stress. And what if you have a label of MCI AD, MCI due to Alzheimer's disease? But anyway, he was well prepared emotionally, so we did the test. And then we discussed disease-modifying drugs, and I'll discuss all this more in the slides. He declined. Now, this was like 7 months ago, but at that time, it was only infusions were available, infusion disease-modifying treatment for Alzheimer's disease at that earlier stage. So we talked about taking early retirement. He really loves pharmacy and his work, but I said, listen, the stress is not good, and you love to travel. This is the time to just travel, have fun. You say you don't have time for exercise, so I don't want any excuses anyway. So he took early retirement, did a host of brain healthy lifestyle interventions, and then again he said no to ApoE testing. We can go into the more details about the pros and cons. And then again, recommended individual counseling for just stress management, and gave a lot of resources. So one of the resources you've been given is, MCI and Hope, where you can read books and read people who are doing podcasts and doing all kinds of cool stuff to live well, in your face kind of MCI living, Anyway, after 6 months, he had stopped drinking alcohol. He still, feels that he could. And me and his wife said, nope, not happening. Brain scare score had improved. His wife said he's a little more lenient than she would have given the score, but that's okay. I'm that way. His hemoglobin A1C was better in just 6 months. So the magic of exercise, nutrition, stress management, sleep. Most important, subjectively, he felt more confident, more positive. He was less worried about the future. But then what happens? Then iClick comes. So iClick is like no infusions. You just stab yourself with this lecanemab, disease-modifying treatment once a week. We'll talk about this more. And so he got excited, like, hey, I didn't want to do infusions, but what are your thoughts about things? I said, listen, all the risks are the same. All the potential benefits are the same. And we'll talk about this in the slides. So after hearing all that, he declined, but he's on the fence. So, all right, let's stop here and switch to slides. So again, the key thing is to realize that for mild cognitive impairment, you have to have subjective complaints, and then preferably even objective sort of evidence. So in this case, his wife was the objective evidence. So besides memory impairment, we need to realize that when we do neurocognitive assessment, we also assess for complex attention, social cognition, perceptual motor, executive function, language. So Montreal Cognitive Assessment is a good scale, but it has its limitations. Ideal would be neuropsychological testing. So when in doubt, send patients to Dr. Black. Next slide. So he had noticed problems in his memory, no problems in reasoning, a little bit of right words. But he, again, did not show functional impairment to the level that I would say is dementia. A lot of this is judgment call. But again, I said this is not normal part of aging. At 74, you should not be having so many problems. There are like sticky notes everywhere, his forgotten phones and passwords and so forth. So Houston, we do have a problem. Next slide. So this is where all the stress comes. So he asked me, so what are my chances of this being early manifestation of Alzheimer's disease, where your p-tau was positive. If it was negative, I can say with very high confidence that your problems are real, but they are not due to Alzheimer's. So negative test is really good. For the positive test, I worry, that this could be early Alzheimer's, and again, we have to just remember that nowadays people go to PCP, say I have memory problems, they do a p-tau and it's positive. That's not the way to diagnose MCI and mild dementia. It's a very thorough clinical assessment. Next slide. So he said, now, so do you think next year I'll develop dementia? So I said, all right, these are the handouts I gave him, say, and all these numbers are before the biomarker age. So we have to just keep that in mind, because with biomarker positive, the number of people who will convert to dementia are higher than what this information shows. But I told him that 1 in 10 with MCI progress to dementia every year, and it keeps going. So if you add like 5 years, the number goes up. I also told him that with the biomarker tests, that research that is available, if you, let's say, we could do a tau testing, so positron emission tomography, tau in the brain, and it was positive, or there are blood biomarkers, but not in clinical setting, in research setting. One of the handouts is very comprehensive information on biomarkers. So again, if we have time, we can go over it. But if, say, the blood test in the research setting was positive, so if you have amyloid positive, tau positive, then over 5 years, 70% progress to dementia. That's very high, right? So it is worrisome. There is no question, But again, MCI fluctuates. Some people get better because a lot of the MCI was primarily due to stress and lifestyle and cardiovascular risk factors and other modifiable factors, and not due to Alzheimer's disease. So I gave all this education because that was his main worry, when will I develop dementia? How fast? Next slide. So as I said, he didn't have obstructive sleep apnea. He didn't have any anticholinergic medicines. The vascular biomarker is mainly MRI at this point. We talked about Lewy body biomarkers because there's a 15% chance, 1/5, that he could have combination of Lewy body and Alzheimer's. At 74 years of age, you can have co-pathologies. And then if you are 80, the co-pathologies are norm. So you have more than one cause of your neurocognitive impairment. But I said, negative tests won't help. Positive tests would be bad news. So we talked about those biomarkers. He said, no, pass. FTD is really seen in younger people. It's more like non-amnestic, like executive impairment, along with some personality changes. And again, probably has, lifestyle induced plus stress induced plus maybe Alzheimer's induced MCI. Next slide. So type of MCI matters because amnestic MCI increases the pre-test probability that this is Alzheimer's disease. So again, I wanted him to get neuropsych testing, but even MoCA was stressful. Imagine 3-4 hour testing. Next slide. Oh, by the way, I also told him that if he has, multiple domain, then that increases the risk of conversion to dementia. So he didn't have that. But if he had, say, amnestic, like memory impairment, plus, say, language impairment, plus executive dysfunction, so 3 neurocognitive domains impaired, so that's multi-domain, that increases your risk of conversion, And I told him the good news is you don't have dementia. And so let's just try and focus on the positives. Next slide. So I said, let's reduce your risk of progressing by healthy lifestyle, all your risk factors that we've identified, hypertension. Again, reduce your exposure to air pollution. This is not evidence-based, but I said no social media, no news, no ultra-processed food, no nanoplastics. He said, this guy is nuts. Anyway, and then we talked a lot about disease-modifying treatment. Next slide. So again, he knew already all the benefits. He wanted to know what's going on. He wanted to know the reversible causes, how to slow it down. They had already done future planning even before coming to me. So the only thing I was able to help them was that, listen, your wife needs to know your username and password. He almost fired me then, but I've had so many cases where, oh my goodness, it has been a disaster because they can't find the password. Next slide. All right. So we can talk more about this, but in general, p-tau is currently reigns supreme for Alzheimer's disease. It correlates highly with elevated amyloid in the brain. But again, all these tests on pre-tau were done in memory clinic settings. So I worry about its use in primary care when we don't have published peer-reviewed articles to support its use in primary care. But you know how it is, these things take over once you release these tests and these drugs. And again, amyloid PET is still the gold standard. It's just not available in our community. Next slide. And again, if he wanted to pursue this iClick lecanemab auto injection once a week, then I told him, then you would have to go and see somebody at our memory center, St. Al's, and then they will order a CSF testing. And if the CSF testing is positive, then you would qualify because you have all the other inclusion criteria and you don't have any exclusion criteria. So you would be a candidate for this. Again, you could do an FTG PET to look for neurodegeneration. That's another biomarker that would increase the likelihood that he would convert to dementia. You can even do now a blood test, NFL, neurofilament light. It's a neurodegeneration biomarker. If it was elevated, he has a higher risk of conversion to dementia in the future. I could also do a GFAP, glial fibrillary acidic protein blood levels. All these are blood tests. If it's elevated, there is a higher risk of conversion. He said, what do you think? I said, don't do it. Next slide. Mainly don't do it because it'll just increase your stress. So, and again, he didn't have chronic kidney disease with GFR less than 45. He didn't have anemia. He had above normal BMI. So the chances of false positives were not there. Next slide.
And maybe more, Dr. Desai, on the why not do the other tests because of the risk of false positives and negatives. There's just more uncertainty with sensitivity and specificity data on those labs at this time, as opposed to the p-tau 217, which has better sensitivity specificity data. So that's why we lean more into those than the glial test and the neurofibrillatory tangle test.
Yeah.
So NFL test. Yes, sorry.
Yeah. So Lindsay, if you can go to the previous slide, Yeah, so again, CSF is excellent test when you can measure A beta 42, just that, or A beta 40 to 40 ratio, or even better, p-tau 181. So different blood tests, tau than blood. But they are very sensitive. That's why that meets the criteria for disease-modifying treatments. But when you come to blood tests for A beta 42, we have seen some studies published where they found very high rates of false positive. So what happens in Alzheimer's is that the A beta 42 goes down and p-tau goes up. Now they found that A beta 42 sometimes sticks to the tubes. So then you will get a false low and you will think that you have Alzheimer's disease, but you don't. It was just false positive because the A beta 42 was sticking to the tubes. So that's the reason, more and more experts, including us in the memory center, recommend p-tau 217. And again, the level, if you go up, it correlates with the amount of amyloid going up in your brain. It's actually scary, That's why I said don't do it every year, because if it goes up, you'll just get more anxious.
Mm-hmm.
All right. Moving on to disease-modifying drugs, the big deal. Let's see how big it is. Oh, wait, look at this slide. So this is really important. Dr. Rabinovici is one of the mega experts in the world, and he and his colleagues have written an excellent paper on when to do amyloid testing, amyloid PET. Tau is, as I said, in research setting. But the key thing is to remember, this is what I was telling him, that even though your biomarker is positive, I don't know how much of this Alzheimer's disease pathology is contributing to your memory problems. It could be just 10%, and the other 90% is all this stress, lifestyle, and things we've identified. So in the future, we'll be doing different tests, which I'll come to. Next slide. So again, if you have amyloid positive, tau positive, it's really bad news. But currently, we have no way to know whether you're tau positive. We don't have any tests. It's all in the research setting. Next slide.
Yeah, so again, just a point of clarification, because it's sort of confusing, right? The test is called the p-tau 217 test, and it's testing for amyloid. So just remember that we don't have a tau test, even though it's called p-tau, it's testing for amyloid.
Right. Yeah. I got confused when it came out, but yes. So p-tau 217 is very specific. It correlates with amyloid pathology very, very early. So at that time, the neurofibrillary tangles have not started to develop and accumulate and then show up on the tau PET scan. So p-tau 217, even though as Dr. Kuntz said that it's tau, it correlates with elevated amyloid in the brain. And remember, as you age, the amyloid in the brain goes up. So that's a whole separate story. Next slide. So again, I told him you are in, there are 6 stages. Stage 3 is MCI, stage 4 is mild dementia, stage 5, but that's clinical stages. And then there are biological stages. In the future, it'll be like cancer treatment. We'll be doing biological staging and then coming up with all kinds of cocktails that target amyloid, target tau, target neuroinflammation. We are not there yet. Next slide. So again, maybe 10 years ago, he was in stage 1. Then 3 years ago, it was just subjective cognitive impairment. Now he's in stage 3. Next slide. So again, core 1 biomarkers, again, fancy term. Basically, if you have blood tests or CSF for amyloid positive for elevated amyloid, then your core 1 biomarker is positive. So in US, we have now changed the definition of Alzheimer's disease to biological definition. Then you would be told that you have Alzheimer's disease. Next slide. Now, core 2 biomarkers, as I said, we don't have it at this point, but these are really where the prognosis comes, or where I can tell you with confidence that, hey, your p-tau is elevated, so your problems are caused by Alzheimer's disease. Stress is adding to the problem, but this is serious. Also, in the donanemab, which is another disease-modifying drug we'll talk about, when they look for high tau on PET scan, that group did not do better than placebo. So again, this is important because if you don't catch the disease early, it's too late, then disease-modifying treatments are not going to help. That's why you have to, if you want to get it, ideally get it at the MCI level or at mild dementia, maybe very mild dementia. Next slide. So biological staging, again, A, B, C, D, we won't go through this, but in the future, this is where the money would be in terms of what treatment to give, whom not to give. Next slide. And again, these are the future blood tests. Nobody's going to have money for tau PET scans, so we are just waiting for blood tests. Next slide. So this is where, again, we need to really help people understand and actively promote hope. Hope is the protector of the future. So again, holistic, strengths-based treatment, resources, planning, modifiable risk factors, brain healthy lifestyle. let's talk about cholinesterase inhibitors. So all the studies and the American Academy of Neurology came up with guidelines on treatment, and they said no to giving donepezil or other cholinesterase inhibitors to individuals with mild cognitive impairment. But all that was based on studies before the biomarkers. So there are many experts who say that if you have MCI with biomarker positive, you can make a case for giving donepezil. Then again, a lot of education to the wife because it's stressful. Even MCI 80 is stressful, and then stressful on the children, and then disease modifying treatment option. Next slide. So now we have 2 drugs approved by the FDA, and this auto injector iClick is a game changer, I feel. But it's like not easy to give, but we'll talk about that. But before it just came out, so it won't even be available until maybe end of this month or next month. Until then, you can get infusions. You have to go every 2 weeks for lecanemab, every 4 weeks for donanemab, and you have to get a lot of MRIs to detect ARIA. I'll talk about that. Next slide. So what will he benefit from? He asked me. So he said it slows the disease progression. It's not going to be a cure. It's not going to stop in its track. How will I know? You won't know. If you're taking the drug and you feel that it's helping you, just believe in that. But there's no way to know, because a lot of placebos population did not convert to dementia. They remained the same for 18 months. And then again, there is research to show that if you take longer than 18 months, 18 months was the pivotal trials. Now we have studies for 3 years, even 4 years, then the benefits accrue. But again, it's by 6 months or more over 18 months. So if you're going to lose your ability to manage your own taxes in a year, you will lose it after 18 months. So we have to remember the benefits are very modest, and some experts and many people feel that they are not clinically significant. We can talk about that. Next slide. So again, I told him that your number needed to treat is 13, which means that I have to give lecanemab to 13 people for 1 person to benefit because of the medicine. So if 3 people benefited, the other 2 benefited because of placebo effect. What about donanemab? Well, the effectiveness is better than lecanemab, but donanemab has more risks of sort of ARIA, the brain changes that we'll talk about. But again, even then, I have to give it to 10 people for 1 person to benefit because of the drug. Next slide. By the way, these are the main reasons he said, no, then I'm not going to do the disease modifying treatments. He wanted the number needed to treat to be like higher, like 1, like every person given benefits. We all want that. So again, reality is we don't have any drugs that will stop Alzheimer's disease in its track. They'll all progress. Next slide. Again, I told him that there are very rare, maybe 1 in 1,000, but people have died. Very rare, maybe 1 in 300, but people have had intracranial bleed and strokes. Very rare, maybe 1 in 300, that you can have seizures. And then 1 out of 5 people will develop amyloid changes in the brain, but there is no symptoms. That's why you do periodic MRIs to detect it. Otherwise, you won't even know. And then if you keep giving it, when they have had these brain changes, amyloid-related imaging abnormalities. Basically, there are small brain bleeds or brain swelling that is going on, but you have no clue. But if you keep giving it, they'll have major bleeds. So that's the reason we keep checking MRI 1 week before, then at the end of 1 month, 2 months, 3 months, 6 months. Most of these are in the first 6 months. Then you can have, obviously, taking infusions, you'll have infusion-related reactions, flu-like symptoms. If you're getting subcutaneous injections, like let's say he said, all right, I want to take the iClick starting September. And we figure out a way where there is a prescriber that gives it. He could have subcutaneous injection reactions to his skin, including flu-like symptoms. It could be systemic reactions too. These are antibodies, human monoclonal antibodies, so they're not benign. Next slide. And then again, this is where, everybody worries, and if 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 he has, say, headache, then I would worry that this could be the symptom of amyloid related imaging abnormality, and I may have to stop the treatment, because if I continue, next time the next symptom would be a stroke. So other experts, like in this article, have concerns that we are not actively tracking how many people are actually dying because of these drugs. So many of us are going too gung-ho on this path, but it's so emotional that I don't blame my patients who want it. Next slide. And again, I explained to him, in the real world, the MCI people did great. In this study, I tell them that, majority of the people who are getting these drugs now are in the MCI stage, and a smaller percentage are in the mild dementia stage. And again, not everybody develops infusion-related reactions or injection-related reactions. 1 out of 5 will have asymptomatic brain changes, but we need to monitor and then stop the treatment. Next slide. And then again, symptomatic ARIA, so brain changes with some neurological symptoms, slurred speech, or, some weakness, headache. Believe it or not, even nausea and vomiting has been described, because that indicates, sort of brain swelling. So that's how you develop it. So anything like this happens, you need to call the office who's prescribing this drug, because they'll need to do an urgent MRI. Because if this is symptomatic ARIA, we need to stop your treatment. But the good news is, I told him that if you decide to take it, then in the MCI stage, you have less likelihood of symptomatic ARIA than if you wait for another month, another year or two, develop mild dementia, and then you decide to go on treatment. It'll still have benefits, but the risk of ARIA goes up. So again, we need to keep that in mind. Yeah.
Just to add here, Dr. Desai, regarding ARIA, it is tricky in terms of access, to getting this medication, but then also the community you live in terms of monitoring for ARIA. If you don't have a neuroradiologist reading your scans, you could show up in the ER with nausea while being on one of these medications. And if they don't know that you're on one of these medications, they won't screen for ARIA, or if there isn't a neuroradiologist trained to screen for ARIA on your MRI, it could get misread and ARIA could be missed. So it is a challenge in that if these medications, to be the most safely administered, should be administered in places that have the resources to screen for them. But that obviously causes disparities, which is one of the major challenges.
Correct. These are these huge system issues that, we need to, or the patients need to realize and be very proactive. So they would carry a wallet card. They would tell the emergency physician, do you know what ARIA is? It's not a name of my family member, and things like that. And even worse, if you have like ARIA-E, edema, and you have a stroke-like symptom, you might get these thrombolytics, which will cause a bleed, because you should not be getting thrombolytics that otherwise you would get to prevent that stroke from getting worse. So again, this is a big deal. Next slide. So again, if you feel dizzy, you have to call me. It could be symptomatic ARIA. That's scary, Visual disturbances, take it seriously. Next slide. Again, if you have some arm tremor, if you're suddenly agitated, if you suddenly have lethargy or delirium, all this is worrisome. It could be caused by the drug you're getting. Next slide. So the good news is that if I do an urgent MRI, there's a good chance we won't see anything, which is good, because we don't want you to have ARIA-E and ARIA-H. E is edema, H is hemorrhage. Most of them are microbleeds, like less than 10 millimeters, rare macrobleeds. So I said, listen, again, depends on how you see it. You'll say, hey, this is great. I want the drug. Next slide. Again, donanemab, everything applies that we've said, Kara and I, but higher rates of ARIA and higher rates of symptomatic ARIA. Now this, we haven't talked about ApoE4, but if he wanted the drug, I would recommend him to get ApoE4 because genetic testing, because if he has ApoE1 copy, the ARIA and symptomatic ARIA risk goes up. But God forbid, if he has 2 copies of ApoE4, the risk is very high. In fact, in Europe, you won't even qualify for these drugs.
And this is really the only setting that we currently recommend ApoE testing, is in the setting of a person wanting to consider these medications because it changes your risk stratification for ARIA. But otherwise, it often doesn't serve a great purpose, genetic testing in the older adult population.
Right. Next slide. All right, I'm going to end with this. Dr. Gawande, his book, Being Mortal, Medicine and What Matters in the End. We are all confronting reality. We're caught in the transitional phase. However miserable the old system has been, we are all experts at it. The old system is that you wait till they have more advanced dementia before you diagnose them. We are experts at that. We know the dance moves. Oh, nothing, it's all aging, come back. With this new way in which we try to figure out how to face mortality, in this case, how to face the prospect of Alzheimer's disease, and preserve the fiber of meaningful life with its loyalties and individuality, we are plodding novices. Really, we are all just started in this whole journey of confronting Alzheimer's disease early. We are going through societal learning curve one person at a time. All right, I'll stop there. A lot of resources and references, but let's chat.
In the chat, Sarah Rogers asked a great question, Dr. Desai. I'll read it here. In your clinical experience, if 90% of MCI symptoms may be due to stress and lifestyle factors, how many people actually change their lifestyle once they realize they have MCI? Why don't you answer Dr. Desai, and then I'll answer, and then anybody else that's had experience with this, we'd be happy to hear.
Yeah, so in general, a lot of people, it's hard to change lifestyle, but when you have certain events, like somebody has had an MI, I've seen radical changes in their lifestyle. It's their wake-up call. So in this person, remember, he didn't change his lifestyle until he realized that there is a prospect that this is the earliest stage of Alzheimer's, and then he was really on top of it. So I think for most people in general, it's hard because we're just so used to an easier lifestyle, but we need to really take it seriously.
In my experience, Sarah, it depends on who's coming with the first initial clinical question. Is it the person with MCI or a family member? If it's the family member and the person themselves is less concerned, we see less lifestyle change. But if the person with the changes is concerned, meaning they're the one showing up wanting the workup, they're far more motivated for lifestyle change, and we see a lot more change then. And, we try to use motivational interviewing in our clinic and really help people get at the source of why they want change, what inspires them to get change. And there's really great data that shows when you can get to the why that is so emotional and personal that it can almost make you cry, that's where change happens, right? We have to tie a real, true, emotional desire to the change in play that we're pursuing in order to see effective change. And then we have to take realistic steps towards change, right, with SMART goals, which we try to use. I see some other people. I know Dr. Black, you've had a lot of experience in this area. You want to say something here?
Yeah, I'll just echo everything you said about who is concerned. And then I would say that individuals who maybe may not even be at MCI yet, but are at high risk. And so people who come into our clinic, for instance, for better or worse, have often had genetic testing done before. They find out they have both alleles of ApoE4. they have strong family history, et cetera, they tend to be extremely motivated to make these changes, but they're overwhelmed about where to begin and which areas of change will make the greatest impact for them. So that's just one observation. But one thing we also do here when we're supporting behavioral change is rather than trying to tackle, let's say, 6 different areas of change at once, try to do an analysis of what are maybe the top 2 areas that if we were able to make significant change, it would move the needle. And often that's around exercise, nutrition, stress management. Those are 3 big ones that we see a lot around. And so, yeah, I would just echo everything you've said. I do think we should think about, though, we're asking people with cognitive impairment of some degree to make really hard changes that are hard for any of us, including without impairment. And so I would just ask for all of us on this call, have that additional layer of compassion that when you're talking to your patient about these really hard lifestyle changes, imagine how hard it is for you when you have all the resources available. And then you throw cognitive change on top of that, and maybe there's some depression and anxiety associated with this as well. And I mean, it's a really steep challenge, and these patients need a tremendous amount of support to effectively make some of that change.
Yeah, thanks, Dr. Black. I also see in the chat a question from Dr. Milliken. She asks, can you comment on the authorization process for DMT, disease-modifying therapies? Have you been successful in getting these approved for patients without CSF markers or amyloid PET, and with blood biomarkers only, i.e. p-tau? So I've seen one case where it's gotten approved with a p-tau serum test alone. Not alone. They had a brain MRI, neuropsych testing, an FDG PET, and p-tau 217 blood-based biomarker without CSF or amyloid PET. But that's rare, depends on the insurance. More often they do want to see the CSF testing. Very often, however, you can get it approved with CSF testing alone and not the amyloid PET.
So I have a question for you two. To my knowledge, no one is offering these DMTs locally, correct? Although obviously with IQ, like that can change. But I've had quite a few people down in Salt Lake City. At least they're going through the process of going through their neurology clinics as part of that workup. But I have the same concern that you raised in the presentation around what happens with local follow-up. So let's say they go down and they go through the infusion protocol, they get the follow-up MRIs while they're there. But if there's an incident up here, and how are you preparing your patients for that, given that their primary treatment team is out of state, whether it's Washington, Oregon, or Utah, but they're physically here the majority of the time? How are you helping your patients manage that, and what type of coordination do you recommend with their PCPs? All of that.
So we have had patients here go to the University of Utah and collaborate with a provider there, Dr. Nick Frost at the University of Utah. He has an Idaho medical license. So they see him there once for a in-person consultation. Often, if they're patients of ours, we do all the initial work up there, and then he does a sort of final stamp of approval for treatment there. And then has them come back to Boise, where they get their infusions here, their MRIs here, and they do telehealth follow-up with him. And he has a nurse case manager whose cell phone she very kindly gives to all of these patients. And she says, if you have any of these ARIA symptoms, and she gives them a list of all the symptoms, I want you to call me. And then she triages whether they need to go to the ER or not, because they're not going to be able to get an urgent MRI. Like, that's not a thing. There's no ordering in the outpatient setting an urgent MRI. It just won't happen. So they have to go to the ER, go through the ER process to get it. And then their team follows to make sure that MRI comes back. They're on Epic. We're on Epic at St. Alphonsus. It gets read by a Gem State neuroradiologist, but then the neurologist at University of Utah does his own evaluation to make sure it was done by a neuroradiologist and that it's appropriate. And so that's their sort of safeguard, and we collaborate with them, and so we're providing education all along the way. I've learned through this that I've educated families on the drug and ARIA and the symptoms monitor. I have documented hours of education. Then they see Dr. Frost, who documents hours of education. And then somehow this family comes back to me for follow-up. And I'm saying, let's talk about ARIA. What do you remember about ARIA? And they're like, what's ARIA? Right? And so there's so much information being given around this drug that there's no way they're retaining it all. I'm sure many of you on this call are struggling to retain all this. It's just a lot of new language and it's overwhelming. And so it does require hours, on average 10 hours of education to support a person around safely being on these medications. So we have to partner with them. And if we aren't doing it, then yes, I would absolutely want their PCP providing that same level of education, being just as educated on what ARIA is, how to screen for it, what to look for. So I'd have great concern if there was a provider in town prescribing it who wasn't able to provide that level of support. Anything else you want to say about that, Dr. Desai?
No, that's exactly the case. We would, if we start prescribing, we would want our system to provide that level of support.
So if I could ask a follow-up, unless someone else wants to jump in, I also really struggle around issues around decision-making capacity for this, right? Because of course, capacity is not a black or white, yes or no, you have it or you don't, but is graded in terms of the decision to be made and the complexity of that decision. And I think around these DMTs in particular, it's such a highly complex discussion, even for individuals who aren't impaired. Perhaps if you felt this was appropriate, you could discuss how are you approaching that discussion with them on these medications to begin with and assessing their capacity to understand what they're even consenting to.
Yeah, we always assess capacity at every step along the way in our clinic. And I think it's an important thing that all providers get comfortable with. There's a tool called ACE, aid to capacity evaluation. And sometimes it is a gray area in which the patient and then their power of attorney work together in this conversation. It is difficult because sometimes the patient is there sort of ambivalent about wanting this therapy, but their loved one very much wants it and is pushing for it. And then I see oftentimes they say, well, if you want it, right? So, and yet we are a family unit. So you can see both sides of that coin. Dr. Desai, you want to speak to that?
Yeah, exactly that case where if the patient doesn't, if I feel that they just don't understand all this complexity, then I just say that I'm sorry, but I think this drug will cause you more harm than good.
That also is maybe an indication that they're more advanced than a person who would benefit from this treatment. I think we certainly see that even if they're in the mild dementia category, if you could justify it based on a MoCA score or what have you, or their neuropsych testing, if they're being deemed as mild, but their amyloid burden is high, they're not as responsive to these medications. And so the benefits probably don't outweigh the risks. And so if their capacity is impaired, they are probably experiencing more advanced disease and wouldn't be a good candidate for the reason of amyloid burden alone.
And to me, everybody should do an opinion.
Oh, there was just to clarify, Julie's asking that good question, that these interventions are estimated to delay progression by 6 months. Do you want to respond to her comment?
Go ahead, Dr. Desai. Yeah.
What was the question?
Just a comment in the chat. Just for clarification, these interventions are estimated to delay progression for 6 months.
Right. So again, remember, this is average. So there are outliers on one end and the other. And again, this is just so emotional that I have patients who every day they feel they can look forward to the day because they are taking this medicine that gives them hope. So this is not imaginary hope. It's influencing their daily life. So to me, but I'm a psychiatrist, so to me, emotions and subjective feelings rule